because coagulation, it is too wide of a topic to cover everything in the 25 minutes. So I'm going to focus more on the coagulation products with some introductions in the field of coagulation. So why is this topic important today? Because essentially the consequences of transfusion and liver transplant are astounding. Compared to other specialties, we have a significant number of transfusion-associated circulatory overload. We also have acute lung injury, transfusion-related immunomodulation, which is good in the short term, but it increases the chance of infections. These are present in the liver transplant patients in a little higher incidence. But most importantly, the things that we are mainly concerned about are the portal vein thrombosis, which occurs in 10 to 15% of patients, hepatic artery thrombosis in 5%, and intracardiac thrombosis in 1.9%. So in addition to increasing the mortality of the patient, they also increase the chances of graft loss. So that makes this topic even more important. Let me start with going over the basics because in order to understand the ways to minimize the graft loss and the mortality in patients of liver transplant, we need to understand the basic sciences. Normally, a slide like this would be a cure for insomnia, but I will try to make it as easy as possible. You know, the platelets start the process of primary hemostasis, where the process of adhesions happens by glycoprotein 1b9 receptor and 1a2a receptors. Von Willebrand factor help in this process, and then the platelets aggregate with each other by 2b3a receptors. The same process that stimulates the platelet activation also stimulates the process of secondary hemostasis, where factor 7 in contact with tissue factor bearing cell initiates the process of secondary hemostasis. This leads on to the amplification process, where factors 5 and 8 are activated, which in turn goes to the propagation phase, where a large amount of thrombin is formed. This is the last step, where the thrombin that is produced in significant quantities activate fibrinogen into fibrin polymers. The bottom picture is that of the fibrin polymer. It has A alpha, beta, and gamma chains. The fibrin polymer also takes the help of platelets at the 2b3a receptors, where platelets bind to the A alpha and the gamma chains, and they form like a very sturdy and solid clot. Now that we have seen the normal process, let's move on to the abnormal process. What happens specifically in end-stage liver disease? The platelet count decreases as a result of decrease in thromboplastin, as well as splenic sequestration. But the function increases as a result of increased platelet aggregation and adhesion. Sometimes it also decreases due to increased nitric oxide and prostacyclin levels. Fibrinogen levels in the acute phase or mild degrees of cirrhosis increases, but because it's an acute phase reactant, but in chronic phase and severe stages, the levels decrease. And there is also dysfibrinogenemia because of increased sialic acid residues interfering with the fibrin polymerization. Intraoperatively also, the platelet count keeps changing due to hemodilution, immune-mediated mechanisms, and also entrapment in the liver. And from the liver graft, the tissue plasminogen activator is being released, and that lyses the platelet receptors, decreasing the functions as well. And the whole process sometimes also activates the platelets. So the whole the sequence of events with platelets and fibrinogen keep changing. It's very fluid. It doesn't stay the same throughout the procedure. With regards to the coagulation factors, the factors that are produced in the liver are decreased, but more important, the factors produced outside the liver are increased. The notable factors are factor 8, von Willebrand's factor, tissue plasminogen activator, and plasminogen activator inhibitor 1. Because of all this, each person is different, each cirrhotic patient is different, and even in the same patient, in different time frames, the picture will be different. They could be hypocoagulable or hypercoagulable, or both can coexist at the same time. So how do we know if the patients at that particular point of time are hypo or hypercoagulable? The only way for sure we can know it is by a viscoelastic test. Conventional tests are not fully capable of analyzing the whole picture. They are like still picture. They give only the analysis of procoagulant activity at one point of time. Whereas the viscoelastic tests are a dynamic test. They give the whole progression of the clot even before the clot starts forming and up until the process of fibrinolysis. Once again, the conventional tests only measure the procoagulant activity. They only measure the acellular components of the blood because the tests are done from the supernatant during centrifuge, whereas the viscoelastic tests are done with the whole blood. So they also measure the interaction of procoagulant with anticoagulant factors, as well as the cellular and the acellular components like platelets and the clotting factors. So just briefly, the top part of the picture is the thromboelastogram, and the bottom is the rotational thromboelastometry. The R time or the clotting time is the time that takes for the clot to start forming or reach an amplitude of 2 millimeters. Clot forming time, or the K time, is the time it takes from 2 millimeter to 20 millimeter in amplitude. The clotting time, or R time, indicates the function of the clotting factors, which we saw in the previous slide. The clot forming time and K time indicates the early fibrinization process, which measures the interaction of clotting factors with platelets and fibrinogen at the very earliest stages. And then we have the alpha angle, which indicates the speed of clot formation, and the maximum clot thickness is measured by maximum amplitude in TEG and maximum clot formation in ROTEM. And finally, the clot starts retracting and lysing, which is indicated by clot lysis in TEG and maximum lysis in ROTEM. So the different manufacturers, the TEG and ROTEM, assign various functions for the alpha angle and the maximum thickness of the clot. The TEG manufacturer says the alpha angle is a function of fibrinogen activation, and the maximum amplitude is a function of platelets, whereas the ROTEM manufacturer says the alpha angle is the speed of platelet activation, and the MCF is a function of fibrinogen activity. Both are right in a sense that the thickness of the clot is dependent on both platelets and fibrinogen. The clot is formed of 30% activity of functional fibrinogen, and the rest will be the platelet contribution. So it is not possible to delineate one from the other. So we need other mechanisms to know if the platelet activity is low or the fibrinogen activity is low. Luckily for ROTEM, they have the FIPTEM that adds antiplatelet agent like teichoic acid to their sample and obtains the fibrinogen, functional fibrinogen activity. For TEG, we have to make a few assumptions. So like I said, there are a bunch of tests which compare the conventional test with the viscoelastic test. And these are some of the notable ones. The conventional tests lead to overtransfusion and TRALI in cirrhotic patients, especially in cirrhotic patients. And TEG has been shown to be superior to massive transfusion protocol, where we proportion the RBCs to FFPs and platelets. It's been shown to be superior in decreasing the mortality in severely bleeding open trauma patients who are receiving more than 10 units of packed cells. TEG also reduces the blood product usage without increasing the risk of bleeding. When someone starts to use the viscoelastic, that's a common question that they have. Would viscoelastic test with the reduced blood product usage doesn't increase the chance of bleeding? No, it does not. That has been conclusively proven also. And in the test that was done in the early 2000s by Dr. Lerner and Sundar in Beth Israel, they noticed in 27 thromboembolic patients, patients who had thromboembolic complications, TEG profiles were hypercoagulable, whereas the conventional test showed only hypocoagulability. It's not surprising because the conventional tests do not measure the anticoagulant activity. They only measure the decrease in procoagulant activity. Moving on to the components of the clotting system, I'm going to cover the topic in the three different pictures that we saw in the first slide, which is essentially the platelets, the clotting factors, and the fibrinogen. I understand fibrinogen is a clotting factor because of its a very important role. I'm just going to cover the topic separately. So platelets, the deficiency of platelets, functional deficiency of platelets is given by decrease in maximum amplitude in thromboelastogram or the alpha angle in rotum in the presence of normal fibrinogen activity. 1 unit or 50 ml of platelets increases the count by 5,000 to 10,000. We will either get from the blood bank random donor platelets most of the time. Sometimes you also get single donor platelets. The random donor platelets, 1 unit, contain a volume of 50 ml. 5 to 8 units are pooled together to give us about 250 to 300 cc's of platelets in each bag. Whereas the donor platelet, single donor platelet apheresis dose comes in 300 ml volume, and it is used in patients who have immune-mediated refractoriness to the random donor platelets. Now is the question for the audience. What are all the triggers for platelet transfusion? It's essentially, like we saw earlier, the maximum amplitude or alpha angle in the presence of severe clinical bleeding. And usually at this time, there will also be a significant drop in platelet count. Even though we said we don't follow the conventional test and we don't take the absolute numbers, it will usually be less than 50,000 when we start thinking about a platelet transfusion. And if it is possible to hold off until the hepatic artery is anastomosed, it's preferable, because platelets increase the chance of clots in high flow systems, as opposed to fibrinogen, which increase the chance of clot in low flow venous systems. Platelets increase the chance of clot in arterial systems. So we wait until the hepatic artery anastomosis is performed, if it's possible. What are the adverse effects of platelets? So the major article paper that came with the adverse effect of platelets is by Bauer et al. In 2008. They showed 1 year survival was dose related to platelet transfusion. And they also saw a negative impact on graft survival, but this was not seen in the multivariate analysis. For this study, they took 433 liver transplant patients and analyzed 26 variables. Of the variables analyzed, the things that decreased the 1 year survival was platelet transfusion and RBC transfusion of other things. And acute lung injury was found to be the major cause of death after platelet transfusion. The mechanism includes the anti-leukocyte antibodies formed from platelets, causing cytotoxic activation and aggregation in the lungs, release of endotoxins, damaging the alveolar lining, increasing the capillary permeability, and causing non-cardiogenic pulmonary edema. Moving on to the coagulation factors. The sources of coagulation factors are fresh frozen plasma or PCC prothrombin complex concentrate and recombinant factor 7A. FFP has fibrinogen, prothrombin 5, 9, 10, 11, and 13. It also has anticoagulant factors like protein CS and antithrombin 3. This is the reason some people think whenever we give packed cell transfusion, we also have to follow it up with the FFP transfusion because it has anticoagulant factors as well. But no studies have been conclusively shown that it is beneficial. In fact, giving more FFPs have only harmed the patient, which we are going to see shortly. With regards to the efficiency of FFP, like we said in the first slide, the whole the importance of this topic is to avoid the adverse effects of blood transfusion. For that, we are trying to analyze which products are optimal and do their work more efficiently. FFP doesn't have that kind of efficiency. It only corrects halfway in the normal suggested dose of 10 to 20 mils per kilogram. It only corrects halfway to normal PT and INR in 15% and completely in only 1%. The median reduction of INR is only 0.2 after the standard dosage. The preoperative FFP transfusion does not decrease the need for RBC transfusion intraoperatively. In fact, avoiding FFP transfusion minimizes the RBC transfusion. This is very paradoxical to see, but that's what happens. We'll see in a second why that happens. Therapeutic benefit of FFP was found only at higher doses, more than 30 mils per kilogram, for it to be completely effective on reversing the INR. And it wasn't seen much in 10 to 20 mil per kilogram dosage. The adverse effects of FFP transfusion, the main thing that was analyzed, the article that analyzed the adverse effect was Massicot et al.'s article in 2008. It showed that FFP indirectly increased the mortality What happens is when the patient is bleeding, we start giving blood products including FFP. This increased FFP increases the circulating volume, increases the pressure in the splanchnics, causing more bleeding in the portal sinusoids. And then we follow it up with giving blood transfusion or Paxil transfusion. This has been shown to cause increased 1-year mortality, the RBC transfusion. So FFP indirectly increases the mortality by increasing the RBC transfusion. Like we saw before, it causes TRALI and TACO. FFP transfusion decreases 1-year survival by 20%, as opposed to 4 units of RBC decreasing 1-year survival about the same amount. So the dosage is 10 to 20 mils per kilogram to raise the clotting factors by 20 to 30%. And that when we give this, only 1/3 of normal amounts of clotting factors is needed to stop bleeding. And this corresponds to PTT increase of 1.5 times of normal values at TEG in the TEG R time of 12 minutes, and in ROTEM, XTEM of 120 seconds clotting time, and then INTEM clotting time is 300 seconds. Moving on to the alternative to FFP, since it has so many complications, we are trying to come up with something that is better than FFP, and one of the products is prothrombin complex concentrate. Both 3-factor and 4-factor products are available, although 4-factor is more common in US, the Kcentra. It has 25 times more factor concentration than the FFP. The benefits are it's more effective. We saw FFP was not effective, but this one is more effective, and it's much faster to achieve the correction of INR, and it's safer because of stringent viral inactivation process. The dose for reconstitution, the volume for reconstitution is much smaller, and it is quicker to reconstitute. We don't have to wait for thawing like in the case of FFP. Some of the studies showed FFP and factor 7A only modestly increases thrombin generation in cirrhotic patients in vitro, while PCC increased to 2 to 4 times. So it's very effective. Fibrinogen PCC use decreases the RBC transfusion and platelet transfusion compared to FFP transfusion. That was found in another study. The adverse effects are very rare. The thrombotic events happen in 7 out of 506 patients, which is the incidence of 1.4%. And once again, this study was done in patients who have thrombotic tendency, who are on vitamin K antagonist. So it's no wonder they had a little more thrombotic events. The dose suggested is 20 international units per kilogram, as opposed to vitamin K antagonist reversal is 25 to 50 units per international units per kilogram. The final factor we are going to see is factor 7A. It is a recombinant factor produced by recombinant DNA technology. It increased the factor 7 levels 100-fold. We saw factor 7 is the first step in the initiation process in secondary hemostasis. And the diagnosis of factor 7 deficiency is made by clotting time in XTEM, or suggestive of increased R time or the prothrombin time. They found that multiple studies were done with factor 7A in early 2000s. The first pilot study showed significant RBC reduction in child B and C cirrhotic patients with 80 mics per kilogram of factor 7A before surgery, followed by small dose 20, 40, and 80 mics per kilogram doses were compared, and this didn't show any significant reduction in RBC transfusion. Lodge et al. In 2005 did another multicentric study which with a higher dose of factor 7A at 80 mics and 120 mics. 80 mic group showed 15% reduction, and 120 mic group showed 23% reduction in the RBC requirements. This was followed by another study done by Neiman et al. In 2006. They showed that the subset of patients had the most benefit were those with high MEL with prolonged PT. In the beginning of the procedure, a dose of 58 plus or minus 18 mics per kilogram was given, and this showed to decrease RBC transfusion significantly in this subset. And finally, another study showed a 90 mic per kilogram bolus used for treatment during active severe bleeding during liver transplant showed significantly decreased blood loss and platelet requirements. So the indications and dosages, it's indicated in severe bleeding during liver transplant after trying out the other products. Prophylactically in high milk patients with significantly prolonged PT, the dose is 90 to 100 mics per kilogram. And thrombotic effects are rare. Moving on to fibrinogen, the diagnosis made by decreased MCF or Fiptum in Rotum, and alpha angle in Tex. The sources of fibrinogen could be cryoprecipitate, the commonly used one, which also contains fibronectin, factor 8, 1 milligram factor, and factor 13. Fibrinogen concentrate, which is pulled from human plasma and stored as lyophilized powder, and factor 13 concentrate is used to stabilize the clots. The dosage, 1 bag of cryo contains 5 units. 1 unit of cryo raises the plasma fibrinogen by 5 milligram per deciliter. 1 unit of cryo contains 150 milligrams of fibrinogen. Comparing a bag of cryo, it has 750 milligrams of fibrinogen with only 400 milligrams in an FFP bag. The dose used to calculate fibrinogen requirement is body weight times 0.2. This gives the number of cryo units required to raise the fibrinogen by 50 to 100 milligram per deciliter. And Rotem-based fibrinogen doses target increase in MCF in Fiptum times body weight divided by 140. Fibrinogen, 2 grams of fibrinogen concentrate in a 70 kilogram patient raises Fiptum by 4 millimeter. Alternatively, the same dose increases the fibrinogen by about 1 gram per liter, or about 100 milligram per deciliter. That's the same dose to calculate the fibrinogen dose like we saw in the last slide, and it's fairly safe up to 8 grams. Question to the audience, is there any benefit of fibrinogen concentrate or cryoprecipitate? Yes, there are a few. It's faster to reconstitute. You don't have to wait 25-30 minutes for the cryo to thaw. It's viral inactivated, so it's much more safer, and there is no volume-based ill effects. And finally, it doesn't have the von Willebrand and factor 8 in them. So in someone who has more procoagulant tendency, this will be beneficial. Factor 13 concentrate used to stabilize the fibrin clots. Diagnosis made by reduction in MA or MCF despite antifibrinolytic therapy. Also increased CFT or K time. Fibrogamin is the plasma-derived factor 13 concentrate. The dose is 10 to 20 units per kilogram. Fibrinolytic system, once the clot is formed, we also want it to lyse. It is a normal physiological process. But in the anhepatic stage and the early neohepatic stage, there is increased fibrinolysis due to hypoxia, acidosis, use of vasoactive agents, and venous stasis. TPA accumulates, PAI decreases. The diagnosis is made by clot lysis or maximum lysis, confirmed with Aptum and Rotem. Treatment is Amicar or tranexamic acid. Dr. Yu Gu Gang's study in 87 showed 1 gram bolus of Amicar decreases the fibrinolysis, and people like Dr. Lerner has showed even 1/4 of the dose is good enough to stop the fibrinolysis, and I agree with that. Tranexamic acid is more effective than Amicar to decrease RBC transfusion. The dose is 10 to 40 milligram per kilogram per hour. This is an example of a flow chart to follow the judicious use of blood products. Leahy follows it. And finally, sometimes we come across this problem. We talked about the hypocoagulability so far, and we are talking about 1 year survival. But when you have clot formation during the middle of the procedure, we are more concerned about 1 hour survival. Incidence of intraoperative thrombosis 1.2 to 6%. 85% happens in the neohepatic phase. This is due to increased procoagulant factors synthesized outside liver and decreased anticoagulant factors synthesized in the liver. Intracardiac thrombus carries a mortality of 68% for the right-sided ones and 95% for the left-sided ones. And the treatment is alteplase or recombinant tissue plasminogen activator. There's a flow chart for the treatment of intracardiac thrombus. If the clot is less than 1 centimeter, we just have to continue to monitor. If it's more than 1 centimeter with stable hemodynamics and starting to propagate, heparin can be given. If the clot is greater than 1 centimeter and hemodynamically unstable, but CPR is not required, recombinant tissue plasminogen activator can be given at 0.5 to 2 milligram dose. And finally, if the patient's hemodynamically unstable requiring CPR, a dose of 1 to 4 milligram can be given via central line, and ECMO or cardiopulmonary bypass should be considered. So take-home message will be take-home taco. That's the last message. Don't give products unnecessarily. Viscoelastic tests should be used for the product guidance. Formula-based as opposed to empiric management should be followed. Avoid platelet transfusion at all. Liver graft is invaluable, so we have to make every possible effort to save it. Thank you all.
Great. Thank you very much, Dr. Uthayashankar, for that excellent talk and overview There's one question in the chat. Have you used PCC factor 7A fibrinogen concentrate in liver transplant? If yes, how do you decide on the dosing?
I've used PCC and the factor 7 concentrate. PCC, we use it a little more frequently. Factor 7, like I said, only when there is active severe bleeding in spite of the normal amounts of coagulation products that had been given. And finally, what was the last thing that you asked? I haven't given the fibrinogen concentrate.
How do you decide on the dosing?
The dose, the ones that I told you, the standard dosing, that's what I do for all these cases. I'm not going to change the dosing in anything, and the standard doses that we just explained is what I do routinely.
Another question.
20 international units per kilogram for PCC, which is much smaller than the warfarin reversal. And with regards to the factor 7, when we give factor 7, it's usually in like a wartime basis. It's not given when you have enough amount of time. So we get whatever vial that is available, we start giving. It's usually given at a dose of 90 to 100 mics per kilogram. One single dose during active bleeding.
Another question we have is, how often do you see the increase of platelet count after liver transplantation when you do not use a platelet transfusion?
So it depends on what phase we are in. If it is in the prehepatic phase, the patient starts with low platelets. It's not going to change significantly unless there is volume loss. Otherwise, it doesn't change significantly in the prehepatic phase. Whereas in the reperfusion phase, because of the TPA being released from the graft, it constantly changes. It definitely starts to go down. So I start ordering platelets around that time and I have it handy. So once the hepatic artery is anastomosed, I start giving it. And usually as soon as we give it, it starts coming up in the next 20 to 30 minutes. It doesn't take too long.
Okay. One final question. What are your thoughts on massive transfusion protocol-based transfusion in liver transplantation?
Once again, the argument for massive transfusion protocol is the FFPs have anticoagulant factors as well, in addition to the procoagulant effect. So they say it completes the picture. Not only we are giving procoagulants, we are balancing it with anticoagulants. But honestly, despite the theoretical advantage, no study has shown that it is beneficial. In fact, they have only shown the more number of FFP we give indirectly increases the RBC transfusion and decreases the 1-year survival.
Great. Thank you very much.